Good evening. I'm Rachel Sachs, Senior Director of Education and Programs at the Cancer Support Community. Welcome to our live webinar this evening. For those of you joining us for the first time, let me tell you a little bit about Cancer Support Community. For more than 40 years, we at the Cancer Support Community have been a relentless ally for anyone impacted by cancer. We help individuals manage the realities of this disruptive disease and get back to a new normal. Whether accessing our free services in person or at one of our nearly 200 locations online or via our toll-free helpline, you are getting a team of licensed professionals providing patient navigation, financial counseling, genetic counseling, pediatric support, and much, much more. Today, we're going to discuss the young onset of colorectal cancer. We have partnered with Colorectal Cancer Alliance to better understand the unique experience and challenges when diagnosed with colorectal cancer at a young age. I'm extremely grateful to have with us today a nurse practitioner and a survivor who will help us understand the experience and unique considerations of colorectal cancer diagnosed at a young age. We are joined today by Heather Tucker and Rachel Klein. Rachel Klein is a nurse practitioner of medical oncology, and here they are. Rachel Klein is a nurse practitioner of medical oncology at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins, specializing in gastrointestinal malignancies and immunological research. She primarily treats colorectal, pancreatic, and bile duct cancers. She is a co-facilitator of the Sidney Kimmel Center retreats for metastatic colorectal and pancreatic cancer survivors. Rachel earned both her Master of Science in Nursing and Bachelor of Science in Nursing from Johns Hopkins University, where she is now an adjunct faculty in the NP program. She also holds a bachelor's degree in International Development Studies and Public Health from UCLA. She is board certified adult gerontological primary care nurse practitioner by the American Academy of Nurse Practitioners. Welcome, Rachel.
Thank you.
Heather Tucker was diagnosed at 36 with stage 2 rectal cancer. She completed 31 rounds of radiation with chemotherapy and had a lower anterior resection and ileostomy. Heather did clean up chemo and later had the ostomy reversed. Heather lives in Arkansas and is married with 3 children and 2 dogs and is a huge patient advocate for colorectal cancer patients and survivors. So welcome to both you, Heather and Rachel. So thankful that you're joining us this evening.
Thank you. Thank you.
We are also grateful for the support of Merck and partnership with Colorectal Cancer Alliance in bringing you this webinar about the young onset of colorectal cancer. So let's get started. This is a question for Rachel. Rachel, can you please start off by describing to us what colorectal cancer is, and also tell us a little bit about what young onset means in relation to a colorectal cancer diagnosis?
Of course, thank you. And thanks to the Cancer Support Community for including me in this really important discussion. So colon cancer or colorectal cancer is a malignancy occurring anywhere in the large intestine or the rectum, which is the section just before the stool leaves the body. And tumors typically start as polyps or precancerous growths, which start in the innermost or mucosal lining of the gut. And over time, some polyps grow into the lining of the colon and irritate it, creating a division of abnormal cells, which then creates a cancer. Not all polyps will become cancerous, but they are an important finding on a colonoscopy because they will usually be removed and evaluated for abnormal features. And other forms of chronic irritation, such as inflammatory bowel disease, Crohn's or colitis, smoking, and a high-fat or low-fiber diet can also lead to dysplasia or the formation of abnormal cells. And because most of these irregularities take years to cause trouble, most people diagnosed with colorectal cancer are over the age of 50. But unfortunately, the incidence of those under 50 being diagnosed is dramatically increasing.
100%. And I think a lot of people on this call have also heard, some big names in the acting field, et cetera, of people who have had some young onset of colorectal cancer. And we might get to this later, but I want to make sure we definitely get to it. I know that the guidelines have changed. So can you share with our audience what the guidelines are and how often one should get some colorectal cancer screening?
Absolutely. So currently the guidelines are down to age 45. It was age 50 for a very long time. Thankfully, actually, thanks to the advocacy of patients and doctors and caregivers who have lost people way too young or who have had to experience this diagnosis way too young, the screening age has been lowered to 45 for the start of colonoscopy, and that's for the general population. Certainly, there are subpopulations that may have either a genetic condition or a strong family history that's been identified, and they may start screening sooner. For example, if someone's mother was diagnosed at age 50, they would actually start screening at age 40. And then, as I mentioned, and we'll go into this, I think, a little bit more in depth later, but the specific genetic conditions that can be identified through molecular testing and personal gene testing.
Okay, great. Thank you for sharing that with us. So Heather, can you tell us a little bit about your experience when you were first diagnosed with colorectal cancer and what symptoms you were experiencing and who you sought help from initially?
The only symptom that I was aware of is that I was bleeding. But now knowing the other symptoms, I did have constipation. I did have some of the other symptoms as well. At first it was just spotting and it wasn't all the time. But then over the years, it got to where it was constant and it was heavy. It took me more than 5 years to get diagnosed. I spoke with at least 5 doctors that I'm aware of. There are 4 different doctors at the local clinic where I go that I spoke with, and at least 1 walk-in clinic, but it might have been 2 walk-in clinics. But it just, unfortunately with a young onset, it usually takes you a while. And I'm not proud of my behavior, but I did get pretty nasty with the last doctor, and I was tired of being tired. I was exhausted. And I had to drop out of several races. I was a runner at the time, and I had to drop out of races because I just couldn't run anymore. I was too fatigued. So
Wow. Wow. So it sounds like you were really trying to navigate and advocate for yourself and getting some answers, but it took quite some time to do that. So that must have been really difficult.
well, they assumed it was hemorrhoids because I'd had children. And so that was always kind of they just assumed it was.
Understood. So Rachel, can you tell us a little bit about what the treatments are that are commonly used to treat colorectal cancer? And does this change for a younger patient?
Great question. So the decision of how to treat colorectal cancer depends on several factors, but actually age is not necessarily the most important factor. It really should start with a thorough workup, which will include a full staging scan, which might be a combination of CT, PET scan, MRI with contrast, as well as biopsies of any suspicious areas. And the oncologist will fully stage the patient to the best of their ability, meaning does the cancer appear localized? Has it spread to lymph nodes or any other organs? And at this point, we also have blood tests that can help us determine whether the cancer may be spreading through the bloodstream as well. That's very exciting, emerging technology. So the biopsy will reveal very essential information about how to treat the cancer. So for example, it'll confirm the type and the subtype, the most common type being adenocarcinoma, sometimes mucinous, signet ring, squamous cell. The location matters, whether it's on the right or the left side of the colon, or rectal. And then the important molecular features that can determine the treatment options, such as microsatellite instability, RAS status, BRAF status. And if you're new to this and that sounds like alphabet soup, know that you're not alone. And that would need to definitely be discussed in a lot more detail with your oncology team. But these initial tests really don't take that long to come back at this point because testing really has advanced. You can get these results back within a matter of weeks. And they really do determine what treatment might be most appropriate for somebody. So I really highly encourage getting that information. Some people will go to surgery right away. For example, if the tumor appears localized, if it's an earlier stage, or if they're experiencing symptoms, as Heather described, that might be concerning for impending bowel obstruction, such as the inability to pass a stool. And those with rectal cancer will typically start with a combination of chemo and radiation, which is also what Heather described, and then surgery. And then for those with a more advanced stage diagnosis, they'll typically start with systemic therapy, meaning chemotherapy or immunotherapy. And surgery may or may not be part of their equation.
Okay, so it really depends upon each individual situation, making the best decisions with your healthcare team, and the stage, et cetera, as you explained. And I guess what we would say to our patients and our audiences out there is that really seeking advice, getting information, empowering yourself, and meeting with your healthcare team, one that you trust to make those decisions is really the best course to follow.
Yeah, absolutely. The internet can be a very deep, dark hole. So starting with a resource like Cancer Support Community, where you know everything's been vetted and fact checked and you know you're getting on the right track to good information is a great start.
Awesome. So Heather, can you tell us a little bit more about the treatments that you received and what challenges and barriers you might have felt related to your treatment that you wouldn't have expected?
I started with chemo pills, the Xeloda or capecitabine, 31 rounds of radiation. And then I had surgery. They removed my rectum and 19 inches of colon. And then they took another section of colon to make me a new rectum, essentially. And they made me a loop ileostomy. So that's further up in your intestine. So that way that everything down below could heal. So I did cleanup chemo while that was healing. And then later on, I was able to have my reversal. I did not finish my cleanup chemo. My side effects were too bad. And I only ended up doing 5 rounds of that. As for the
Okay.
barriers, I didn't expect it to be so expensive. I mean, you know that medical stuff is expensive, but so they had me on 2 different prescriptions for the pills to get the right dosage. I'm assuming for my weight. I'm not sure, but I had to be on 2 different ones. And so if I had gone with the brand name, it was going to be $4,500 each prescription. So that was $9,000 just for that, not including radiation and everything. So I was very lucky that I had good insurance, even as a stay-at-home mom. And a lot of it was actually covered. But I was not expecting the price tags on a lot of it. I was also warned about all the side effects. The doctors will go over all the side effects with you. I just didn't realize that a lot of them would be lifelong or they would be as bad as they could be. And then mostly, it wasn't what to expect. It was surprising, but to the extent, like you say, oh, you're going to be tired. But even having 3 small children, I had never had such tiredness before. You're tired to your bones. And the exhaustion, the loneliness, even like in the infusion center, your friends don't necessarily know how to talk to you. The strain on a lot of relationships, you lose friends usually, things like that. Those are not in the medical index cards with the prescriptions. So.
Wow, Heather, you threw out so much there that, I mean, we could probably have 6 webinars and everything you threw out. So thank you so much for your honesty and transparency and sharing. So important. One thing, I'm going to go a little bit off topic because you shared such important information, the cost of care. And that's a huge concern, probably for our listeners and people that we hear from on our helpline and cancer support community. So luckily, like you said, you had great insurance. So I just want to reference a few things, and then Rachel and Heather, if you want to chime in as well. What we would say to our audience is that we have a helpline. We're going to put that in our chat right now. We have fantastic financial navigators. So if you're struggling, even if you have insurance and you're struggling, please reach out to us. Also, at most of your clinics or your cancer centers, there are financial navigators, there are social workers. Hospitals are there to treat. They are not there to turn you away, and they will help you find a way. So please seek treatment. Please get the care that you need because it's critical. We don't want you to delay because of the concern of cost of care. Rachel and Heather, anything to add to that?
I mean, just second it. Don't let costs be prohibitive to you receiving care, because the earlier you get care, the better. There are usually social workers at clinics and things like that, and they will help you if you have off work and you're losing your pay, things like that. Like, you don't have to face it alone.
Love that.
I would echo that. And also to just be, don't worry about stigma or feeling ashamed of anything like this. We all know, I mean, the cost of healthcare in this country is universal knowledge, and this is a strain no matter what your income level. And so just mentioning to your doctor, hey, this prescription came out a little more than I was expecting, or the pharmacy said there's an alternative, or, is there an alternative? As Heather mentioned, there might be two brands. Sometimes there's a generic that's just as effective as the brand name. Sometimes there are patient assistance programs. A lot of times when we place a prescription, I'll just tell you from the provider side, I have no idea what your cost is on the other end. There's no way for me to know. Even something like Zofran, which is commonly used for nausea, can be very expensive, and I'm seeing more and more prior authorizations required. Those can be very time consuming, but if you don't let your team know that a prior auth was required and you had to pay out of pocket for something and it was quite costly, we have no idea. So please, please just communicate all of that back to your team and find out, what alternatives and cost saving measures there can be, because there are a lot.
Great information. The other thing, because I know we're going to get to side effects in a moment, and Heather, you touched on that. So important. But one other topic that you really brought up, and I'm so glad that you're here with us, is the relationships and how some of your friends, it was difficult because they wanted to support, but they didn't know how to support. And that often sometimes gets tricky and sometimes can affect the relationship. And then that can lead to isolation. So again, what we want to stress to everybody that's listening, whether you're a survivor, a patient, a family member, an advocate, what have you, that there are support groups out there through Colorectal Cancer Alliance, Cancer Support Community, and our Gildas clubs. There are social workers, and they can help connect you with people that understand what you're going through, and also help guide you in terms of when if you feel that you want to talk, to friends, or how to talk to friends and loved ones, that is okay sometimes that you don't want to talk to them at a certain point, what to say, how to guide you in that, and really give you that level of support. Heather or Rachel, anything to add to that?
I think just in terms of some services and things that I would recommend, just to roll on to that, you're absolutely right with your HR or school counselor. If you happen to be enrolled in school, find out all of your options for your time off, FMLA, short-term disability, long-term disability. As I mentioned before, we have great, amazing healthcare resources in this country, but unfortunately our insurance is often tied to an employer. So you need to find out how to keep your benefits, how to maximize any paid time off you have access to. Some creative solutions I've seen some of my patients look for are asking about alternate positions that could be less physically taxing or allow for more flexible or remote work within the same company, so they're able to keep working. And a lot of people do keep working during treatment. Mm-hmm. Some side effects are manageable, maybe with a dose modification or a break. And so there are ways that you can work with your healthcare team to make the side effects manageable for you. I would really, truly say you're not supposed to be down and out 100% of the time on chemo. That is not my expectation. My expectation is you can realistically do about probably 80% of what you were doing not on chemo. That's the truth is. And I tell people that if you feel that you are dropping below that 75, 80% of your capacity to do the things that you would love to do on most days, I need to know about it. We need to make a change.
Absolutely. Absolutely. So going right into that, Rachel, can you talk about some of the side effects? Heather definitely talked about the fatigue and how real that was and extreme, that may result from treatment for colorectal cancer.
Sure. So we talked about, so the most common chemotherapy side effects are the ones Heather listed. So fatigue, nausea, neuropathy, which is numbness and tingling in the fingers and toes, a drop in blood counts, risk of bleeding and infection, and then the peeling or sensitive skin on the hands and the feet. And then for those receiving immunotherapy, for those who have the microsatellite instability high molecular designation, they might experience a range of autoimmune toxicities such as rash, diarrhea, or arthritis. And most of these resolve after treatment is discontinued. Some may certainly persist longer. But I think the longer term, and Heather, you can speak to this, a lot of times I see the longer term side effects are usually those from radiation and surgery, particularly with rectal cancer, because the rectum is responsible for absorbing water out of the stool to make it formed before it leaves the body. So if the rectal tissue has been radiated or resected, people often experience loose or frequent stools, a sense of urgency. Pelvic radiation can also cause infertility and early menopause. So this may be a consideration, for younger patients who are hoping to preserve their eggs or their sperm prior to starting treatment.
Heather, do you want to add anything to that?
I think she touched on what she had said before about letting your doctor know. That was one of my biggest problems. That's the reason I have so many side effects still is I'm neurodivergent. And so when the medicine comes with a list of possible side effects and then I experience those side effects, I just assume, well, you suck it up, you're going through cancer. I didn't realize that the amount of things they could do to help me and adjust medications or giving me things to help with different side effects. And I didn't do that. And so that was one reason why I ended to clean up chemo earlier, was because my side effects were so extreme. So I still deal with a lot of issues that I shouldn't have to deal with if I had realized. So always talk to your doctor.
Well, it sounds like now you're a huge advocate for everybody out there to advocate for themselves and empower themselves, which is fantastic. And two people, and I'd love to hear from you, Heather and Rachel, that I think sometimes either get consulted late or our patients don't know about, and we're really trying to, a cancer support community, make sure our patients do, are the pharmacist and the nutritionist. And in terms of the pharmacist, I mean, I can tell you the pharmacists are patients' best friends. And they can absolutely help with those side effects and before side effects occur, and really educate and counsel patients and their families. And nutritionists, Rachel, I don't know if you've had this experience, or Heather, sometimes I think they're consulted way too late. And they really should be consulted in the very beginning. Can you share your thoughts on those two professionals and their role in the plan?
Absolutely. I mean, pharmacists are my best friend too. I utilize them all the time. Certainly important for managing and preventing drug interactions. A lot of young people aren't really on other drugs. They don't have a lot of chronic comorbidities. And so that thankfully is usually a simpler calculation for most of our younger patients, not always, but yes, I think they're a great resource. It's great if you can get to know your local pharmacist that you're picking up all your medications for, especially so they understand when you're picking up things like pain medicine, and you just build a trust, and then you don't feel like you're always being scrutinized. In terms of nutrition, I think you're absolutely right. They should be consulted early on. Some people don't have as much of a problem keeping up with caloric intake, and there's some basic guidance certainly that I provide without necessarily doing any of the deeper dive caloric measurements or day-to-day diary logs. I think in general, we would recommend a high protein diet because you tend to lose muscle when you have cancer. Muscle is the first thing to go. And that just takes away a lot of energy. When you have less muscle doing the same work, it makes you more tired. And it takes a lot of energy to fight cancer. So a high protein, generally low sugar diet. And then fiber is something that's give or take. That's something definitely where a nutritionist can come into play, because depending on whether the colon tumor has been resected or not, there may be different guidance on whether you're supposed to eat a high fiber diet or a low fiber diet. Certainly high fiber is recommended in survivorship. And we'll talk about that a little more in a little while, but and also for prevention. But if there's a colon tumor that's potentially obstructing the path of stool, sometimes high fiber is not always recommended because you can become obstructed.
Okay. Heather, anything you want to talk about in terms of what you did for your diet, or any other professionals that you felt were like absolutely key in the process of helping you?
So for me, I live in a very rural part of the country, and so we don't have a nutritionist at our clinic. That's my doctor. He comes just a couple days a week from Little Rock, so it's about 80 miles away. So it's, you talk to him and that's what you get kind of thing. For me, like I was on a low residue diet, especially while I was healing after surgery. But what I found for me, especially since I was so fatigued, like, by the time I fixed the kids' food and everything, I wasn't cooking for myself. That was out the window. But I found just protein shakes. The pre-made protein shakes, I could keep them by the bed. I could lay down and, up my protein without a bunch of sugars and things. And I do think that that made a difference, having a high protein diet. Um, the good part about being in a small town was that his nurse and the surgeon who found my cancer to begin with, I knew them personally in my real life. And so being able to call people and ask questions, make friends with your nurses.
Yeah, nurses become your best friends. Absolutely. I know our nurses at our clinic. I mean, they're like family, right? It's one big family, and you really grow to develop an intimate relationship with them, and they care so, so much.
They do.
And our NPs
Of course, but they're
and our
just so
physicians and the whole
busy.
healthcare team. Don't want to leave anybody out.
Well, Heather, you raised a good point that I just wanted to piggyback off of, just being in a small town and hopefully feeling that, support of people around you. I encourage people to be as specific as possible when people offer help. I encourage them, and Rachel, you as a social worker maybe can speak to this. I encourage people to be as specific as possible with what they need or what they want. If somebody offers to bring you a meal, thank you so much. Here are 3 recipes that are appealing to me right now. My taste buds are really off during chemo, and there's only certain textures or flavors or temperatures that are appealing to me. I would love any one of these 3 things. They will bring it to you.
Let them.
Yeah.
They want to do something to support you and they don't know what to do. So let them walk your dog, let them bring you groceries, let them do your laundry, whatever you need, let them do it.
That's right. That's right. And there's lots of services online. We have one at Cancer Support Community in terms of that you can actually write down, what you need and what services would be helpful to you so that you're not having to answer every single text or every single email or every single phone call, because I'm sure, Heather, you can attest that that can get really tiresome too, and having to repeat your story over and over again. Also transportation, use that. Heather, I assume you said, you were a stay-at-home mom, but, you had 3 kids. So if you were tired, I'm sure transportation might have been an issue for you. But get that lifeline of friends, again, at your cancer support communities, your churches, your synagogues. People do want to help. And I think Heather kind of indicated that sometimes they just don't know what to do. And sometimes they'll throw a million things at you and it's too much. But just outline specifically, like Rachel and Heather said, what exactly you need and what could be helpful. And that can change over time too, right? So you might need transportation the first couple of months, and then maybe later it might be, like you said, walking your dog or taking your kids to a soccer game or something of that nature. But be honest, because people really do want to help. They just sometimes don't know how. Okay, awesome. So for both Rachel and Heather, what are some other services or other consultations that you would recommend for our younger patients to pursue? And when should these take place? For example, I think we touched on, Rachel, fertility preservation. There's also, mental health support groups, et cetera. So can you touch a little bit about that?
I love this question because it's a great reminder that the oncologist is not the only person on your team. We need to hug you in a circle of support and resources, especially as a young onset colorectal cancer, survivor. And so fertility, again, depending on what your plans are, whether you're partnered, whether you want kids, all that, that may be something to talk about pretty early on, especially if radiation is in the mix. I would say that's the biggest risk factor for losing fertility. Even if you are not planning to have children or have any more children, for women especially, I would encourage getting looped in with a GYN that specializes in this type of survivorship. There can be a lot of navigational challenges later. Sometimes with radiation, you may even use dilators, vaginal dilators. You may have difficulty with intimacy later on for different reasons. So these are things, again, not to be ashamed of, and just to know that this is a normal part of life, and this is And going through menopause at age, 25 or 35 versus 55 is a really different experience, and you might feel really alone, but there are people who specialize in this. You also mentioned mental health. I think this is huge. I encourage everyone, if they do not have a therapist at the time of their diagnosis, to get one right away, even if they feel like they're coping well, even if it's 99% curable, even if XYZ, get your own support that is not your family and friends. You need a neutral person that gives you permission to express your feelings without the fear of judgment. I would say that's pretty essential. And then finally, I think anyone with an advanced stage diagnosis, I would encourage them to obtain a second opinion at an NCCN designated comprehensive cancer center. Heather, I'm curious to know if this is something you did. I know you're from a small town. It was a small hospital. I'm not sure what their resources were, but I imagine that it probably wasn't an oncologist that very, very narrowly specialized in colorectal cancer, probably a community oncologist.
Yes.
And clinical research is always evolving. There's so many exciting drug trials right now, and you want to see someone who's really specialized so they know what's happening. We're going to the conferences that are discussing this very diagnosis all day long for days on end. And they also, large cancer centers also may offer specialized procedures or surgeries that aren't offered elsewhere.
Yeah. Heather, anything else?
Yeah, my local clinic, he just treats cancer. So whatever comes across his desk, that's what he treats. And I'm grateful for him. He's a very good doctor, but he cannot physically keep up with the research for every type of cancer he's currently treating because new stuff comes out every day. And so you do need to be looking into your own research. The surgeon that found my tumor with the colonoscopy, thankfully, like I knew him outside of his work. Our kids were at the same preschool. And so he sent me up to St. Louis. So I did go to Siteman Cancer Center for surgery to have he said, I can do your surgery. He said, but you're too young. He said, you need to go have someone. That's all they do every day. They specialize in this. And I appreciate that he did that for me. So yeah, you can always take a second or third opinion, whatever you
Yep.
need.
Or fourth. Sounds like you had a great advocate there. Something that you touched on, Rachel, that I really want to make sure, particularly for our young adult onset colorectal cancer patients, is intimacy and dating, which is huge because dating might be a huge factor for our listeners. Intimacy, how to have those conversations about changes to your body, how to feel comfortable, and that there's not just one way to be intimate. And also how to have those conversations, not only with your partner, but your healthcare team, because sometimes, people feel like that's taboo. So just wanted to get both of your takes on that.
I'll let Heather start on this one since she was married at the time of her diagnosis, I think, right?
Yeah, it was not easy. I definitely did not feel sexy when I had my ostomy. And I was thankful that the internet came to my aid, because there are things that you can wear and things you can do. You just have to be open. Cancer will take a lot of your privacy away in all areas. Doctors are gonna poke and look at things that you don't want to show, and you're gonna have to have conversations you don't necessarily want to have, but it is essential. I'd been married 14 years at the time, and it was still a hard conversation to have. Even though he'd seen me pregnant 3 times, we'd had babies, we'd gone through fertility treatments, the whole work, it was still difficult.
Absolutely. Absolutely. Thank you for sharing that. And also, I guess one thing is that I want to ask whether somebody we're dating or our family or a partner for patience, right? Patience is so, so important, and to kind of be where we are. But I think you're right, Heather, having those open conversations is so critical. Rachel, anything to add?
One thing that we talk about in our chemotherapy education class is how chemo can be transmitted through body fluids. And just from a safety standpoint, it's about 48 hours until those drugs are out of your system from the last dose. And a lot of times just giving that information and, recommending using a barrier method, for example, if you're going to be intimate within 48 hours after chemo. A lot of times just mentioning that just sort of opens the door for these conversations. People say, oh, okay, this is something people ask about. This is something people care about. And just sort of talking about, what can be transmitted through body fluids and what types of body fluids and by how much. The answer is you're not going to harm your partner. It's a very, very trace amount. But like you said, it's just best to be as open as you can. Hopefully you can build that trust with your team that you feel comfortable at least asking one person, whether it's the nurse, the NP, the oncologist, the pharmacist, just one person that can, be a resource.
Absolutely. And I think it's important to share with our audience, you don't have to feel like you're best friends with every member of your care team. You want to feel very comfortable with them, that you can be open with them, but definitely form a connection with somebody who you can completely trust and go to, who's your go-to person. Wouldn't you agree, Heather, just to find that one person is really critical?
Absolutely.
Yeah. So we did answer, I got to it early on, questions about screening that you addressed, Rachel, but I want to ask you, is there anything people can do to prevent the risk of getting colorectal cancer? And do genetics play a role in colorectal cancer being diagnosed younger?
Absolutely. So we talked about the screening age starting at 45 now. With a first degree family member, you start earlier, or if you're experiencing concerning symptoms such as rectal bleeding or digestive symptoms, these can often be very vague. There are certain genetic risk factors, although all cancers, I want to be very clear, all cancers are a combination of genetics, environmental factors, and lifestyle. So there's no cancer that's only here because of one of those things. They all play a role. For different people, there are different slices of the pie, different percentages of risk. So for example, Lynch syndrome, a genetic condition, inherited condition in which someone's cells mutate at a faster rate than others. Someone is more at risk to develop any cancer in certain cancers in their lifetime, not just colon cancer. So that's something that they need to work with their primary care and probably a cancer center to identify exactly what screening, and a genetics team also, that's something we didn't mention earlier, but to identify what screenings they're going to need throughout their lifetime. There's also something called FAP, or familial I always struggle with this word, adenomatous polyposis. It's a mouthful.
Good for you.
FAP is much easier, which basically means it's somebody that has a ton of polyps all through, often their colon and their stomach. And often this is something that will promote a gastroenterologist or a surgeon to recommend a preventive surgery. So we do sometimes see young people that have had a full colectomy or full gastrectomy to remove the risk of these polyps and therefore prevent cancer in that way. And then we know so much more. This is the age of information and genetics. It's no longer expensive or difficult to get access to these genetic tests. There are tons of third-party ones that you see advertised on the internet. I do recommend going through your healthcare team. That's a little bit more private, and you can then get referred appropriately to genetics if needed. But there are other markers that we have identified now that put people at risk. So the best way to reduce your risk in terms of lifestyle is to avoid smoking, excessive alcohol. We're learning more about alcohol as a carcinogen, particularly for liver cancers, but also for colorectal. Moderate red meat intake, and then eating a diet of mostly plants. What this does now, we're learning a lot more about the microbiome. It strengthens the mucosal gut lining to diversify the microbiome and keeps the walls strong.
Great information. Heather, so as a colorectal cancer patient advocate, is there anything you want to share with our audience about, which you shared a little bit, but anything more about screening? Because there's such a fear, I think, amongst people about having to get screened for colorectal cancer. And that the process is so difficult, which, I've gotten screened multiple times, and I would say it gets better and better, right, Rachel? Like the process gets, I think it's getting better and better in terms of some of the solutions and things that you can take and what have you. but there's still that real fear out there about it and stigma. Anything you want to share, Heather, as an advocate?
I just want to say that it's come a long way. The preps, you used to hear the nightmare stories about the preps and all.
Exactly.
But there's so many options now. I just had one like 3 weeks ago, and I did Sutab. So you don't drink anything nasty. It's tablet form. You do have to still drink an abundance of water, but it's very, very
That's
simple.
what I did. It wasn't too bad.
I loved it. It's not aggressive. It was easy to do. I didn't have to like stay in my bathroom the whole day with a good book. Like, it was much better than previous ones I'd experienced. And then also the camera is so teeny tiny. It is smaller than a normal bowel movement. So you don't have to worry about being in pain. You're going to wake up after having an excellent nap, and it's going to be all good.
It's great. Rachel, anything to add there? I mean, you see two advocates here just saying great things about the Sutab.
Yeah, I think that, so there are I just want to mention there are other ways of screening out there, such as, stool tests that look for like the DNA of cancer in the stool, as well as now some blood tests actually being developed at Johns Hopkins that are working to find early detection. So I think that we're going to continue to evolve in technology. I just did want to mention, though, that currently the stool tests are not approved for people who are high risk. They are only approved for people who in the general population who might be at general risk. But if you have friends, for example, Heather may be an advocate to her friends and for the general population in getting screened, maybe they're not ready to start with a colonoscopy. Maybe they're ready to start with a stool test. Even as awkward as that sounds, we all know pooping in a cup it's no picnic, and putting it in the mail on ice is a little strange, but way simpler than doing the prep and getting a colonoscopy. So if that's the minimum that you can encourage your friends to do, that's a great start.
And it's
Awesome.
a great option for homeless people, for underinsured people, for people with no insurance, for people who are undocumented and afraid to go to the doctor's office. A FIT kit, a fecal immunochemical testing kit, is a fantastic option.
Awesome. Perfect. So Rachel, let's talk a little bit about survivorship. And Heather, I would love for you to weigh in here as well, obviously, as a survivor. So Rachel, what does survivorship look like for this unique patient population, our young adults? If you can tell us a little bit about that, and what makes the experience of colorectal cancer as a young adult different or more challenging during the survivorship phase?
So one thing I like to say is, in a lot of places, they define survivorship as actually from day one. So from day one of diagnosis, you're in survivorship. You are living with this disease and you are a survivor. Some people like to say it's when treatment ends, it's a new chapter, but I like to say it's from day one, just different ways of defining it. And it's very complex. And we've touched on a lot of the ways that you can feel like your life is turned upside down. And there's the spiritual and mental health component, there's exercise, sleep, surrounding yourself with people who make you feel good, on good, or who let you be yourself on good days and bad. But I think really when we're talking about survivorship, we have to talk about the two buckets, and the two different, big dividing, the dividing factor, which is those that are treated with a more curative intent, those whose cancer can be cured with the tools that we have available today, and those whose cancer cannot presently be cured with the tools we have available today. And I word that very carefully because I'm an optimist. I work in an academic medical center where I see new things being developed and approved, all the time. And we're making progress there. And so even someone whose cancer may not be cured today might be cured in a year or 5 years. And we need to use all the tools that we have in our toolbox to give someone the very best outcomes. And so really, I think survivorship from that standpoint does mean a different thing to so many people. Living long-term with side effects, God willing, for 50 more years from someone's diagnosis, or even 60 more years from diagnosis, is going to look really different than someone who's focusing on metastatic survivorship, and how they're coping with decision-making and what's going to happen with their children and what's going to happen with their spouse, and sort of anticipatory grief of things unrealized. And that sounds heavy because it is, but it's also real, and it's important to acknowledge and provide the support for that population.
Beautifully said. Heather, so tell us what survivorship has looked like for you and what your new normal is.
I want to say my new normal is my baseline for tired is much drastically changed. I've gained weight. I have some food intolerances that my new system just does not allow me to partake in. Also having to gauge like, okay, can I eat this now or do I need to wait until after the Zoom meeting because you don't have any issues? Because I have lower anterior resection syndrome. Then they have a thing called anxiety, where you have anxiety really bad with scans, or white coat syndrome. And I do think I suffer from that a bit. Like I said, I just had my colonoscopy not too long ago. My blood pressure was really high when I got there, and I had absolutely zero reason to think that anything was going on. It should be absolutely clean. But I was still a very high stress situation, having one again. So
Sure. Scanxiety is very, very real. You know, whether it's colorectal cancer or another chronic illness, or sometimes just going to the doctor for your regular physical. What we would encourage you and everybody listening is don't let that get in the way of getting the help and getting the care that you need. What's really important is finding those trusted people you can talk with. Like Rachel suggested, finding a therapist or a support group, and feeling comfortable with your care team and making sure it's right for you. Are there any additional tips or support services that you want to share with our listeners?
I think the biggest all-time universal tip is get a bidet attachment for your toilet. It's worth every penny, and you can get them for under $25 on Amazon, and they don't take that long to install. Yeah, that's my biggest tip.
A good tip. That's a great tip.
Great idea. And squatty potties. I'm one of the biggest advocates for having a stool. When you realize what direction the colon faces, you'll never want to go to the bathroom without your knees up again. Yeah.
There you go. If each of you were sitting with a newly diagnosed young patient with colorectal cancer right now, what are a few important things you would want them to know? Heather, let's start with you.
Okay. The short list is things we've already mentioned. Get a bidet attachment and add squatty potty to that. Let people help you. It's good for them as well as you. Don't be afraid to get a second opinion. Trust your gut if you need to see someone else. Research, not deep diving on Google, but if you find out you have your KRAS or whatever, then look at that and see what that means. And see, because there are treatments specifically for that. And don't expect your medical team to do all of the legwork on that. You need to know what you're walking into. Advocate for yourself, or bring someone with you that will advocate for you, to ask the questions, to tell them if there's something wrong or that you want to change something, because you do have a say in your treatment. You have the power there. And then you can always call me.
I love that. I love that. Thanks, Heather. Rachel?
I love that. I had several of those on my list as well. I will say, take someone with you to the initial appointments. You will not absorb everything in those first few visits, and don't be afraid to ask questions more than once, because chemo brain fog is real and we know it. Filter well-meaning but bad advice from people. And then if something's bothering you, share it with your team. We're always here and we're on your side. And even if you don't like the answer, ask for explanations, find out, but really, truly, we're on your side. And the last thing I want to add, because we really haven't touched on it at all, is I want to clarify what palliative care is and why they should also be included up front. So palliative care is a team that really, truly focuses and has an expertise in symptom management. And so that could be everything from pain, constipation, nausea, as well as how to navigate uncertainty, stress, and complex decision-making. And at my institution, they dubbed themselves the quality of life team. And so a lot of people who aren't familiar with palliative care just immediately associate it with hospice or end of life, but really they can be such a valuable resource throughout your entire journey.
That's really great information. And stay tuned, everybody, because we are right now in the process of developing a piece, particularly for caregivers, about the difference between palliative care and hospice, because there's a lot of confusion about what that is and how palliative care, the team can get involved very early on in the treatment process. So now's a great time for our audience to drop any questions you might have into the Q&A tool. But two more things I wanted to really address. Heather, you brought up a really good point, and I wanted both you and Rachel to weigh in on this about shared decision making. And I think that a lot of patients, I think that, and Rachel, maybe you might be able to share this, our younger patients are really, we're in a generation of real advocacy for ourselves, right? And empowerment. But what's so important is that you have a say in your treatment. You have a say in your decision-making process. So don't feel that you can't question the care team, that you can't share information that you have, and that you can't get that second or third opinion. Rachel and Heather, anything else to share about shared decision-making?
I would say don't be afraid to ask the question from a place of curiosity. You could frame it as a place of coming from a place of curiosity. You know, is this my only option? Or I'm curious if there's any alternative, or what happens if XYZ, my biggest fear, or my biggest fear about this is XYZ. You know, just framing it from a place of genuine curiosity. If you really think that something's, you know, your gut feeling tells you something's really wrong, that's a different story, I think. But in general, there may be slight differences in what we can offer, or there may be two options. And we say, yeah, we can add this drug in now, or we can start with this and see how you tolerate it and maybe add that drug in later. Or it's really important that you start with, and they will explain, yes, it's really important that we start with all of this up front, and we can always drop things, or we can always modify, or we can add more anti-nausea meds. But it's totally fine to ask the questions.
100%. Heather, anything else about that?
Just, I mean, exactly what she said. Don't be afraid to ask questions, but your doctor will usually explain all those things to you. He will say, you know, my doctor said your tumor's between 8 and 10 years old, and we're going to go with the standard of care. We don't think you have Lynch syndrome, and until we get a test back, we won't know. But I mean, he explained all of those things to me. If he's not explaining it to you, ask him for sure.
Okay, great. And before we open up the forum for questions, any one last piece of information or advice that you want to leave with our listeners tonight? I think you said it all.
Is that a mouthful?
We said all wonderful things. One thing I'll say before handing it over to Rachel is feel empowered. Make sure you get a team that you feel comfortable with. Like Rachel said and Heather said, ask those questions. And know that you're not alone. There is so much support there out for you. Rachel, anything else before we get to some questions?
Well, I think this was an amazing discussion. Thank you so much for the opportunity to share.
Great. So in terms of some questions, somebody shared, I imagine that a colorectal cancer diagnosis may affect the connection between partners. What are some recommendations for how to best address those concerns? Rachel, do you want to take that?
Sure. I think it depends on the issue, certainly. You know, if it's bringing up questions about support, you know, my partner I'm having a hard time feeling supported by my partner. There may be, you know, communication barriers. You know, if it's intimacy related, I mean, there's such a range of, you know, there's overwhelm, there's caregiver fatigue and burnout, right? We didn't even touch on that. That's probably a whole nother webinar, Rachel.
For sure.
Right.
Well, we'll get you to talk about that one, Rachel. Don't you worry.
Exactly. There's just so many ways, but I think, you know, a lot of times I think I have seen stress between partners when they don't attend appointments together. And that can be really tricky if you have a young family, or maybe you're not yet like long-term partners, especially for young people. Maybe you're just kind of girlfriend, boyfriend at this point. You haven't, you're not like, you're not sure you're in it for the long haul. There's just some uncertainty there, or maybe, again, there's, they're working or they're in school and they're just trying to hold down the fort while you're in treatment, but they're not coming to every appointment with you. And then that information gap causes some stress. And so however you can kind of stay on the same page and share what you feel comfortable with, I think that's one piece of advice that I would offer, is to just keep them in the loop if they're not able to come to anything, or try to make, every once in a while, make a video visit, ask for a telemedicine visit with your oncology team, so that you can both attend from home and sort of have like a catch up moment where you all get to be on the same page.
Perfect. Heather, anything else to add to that?
You did good.
Great. Marcy, I know you have something to share with our listeners.
Yeah, so we'll be placing an on-screen poll here in the next few moments to hear about experience you've had today with this webinar. For our audience members, if you could take just a few moments to complete that poll for us, we would greatly appreciate it. And while we have this up, I do want to jump to a question that we received from an audience member. So they ask, as a patient navigator focusing on screening, I speak to patients under the age of 35 more and more often. What would be the best advice for these patients who are not listened to by their doctors or are having a hard time getting screened due to their age? Rachel first, maybe?
Oh, that's so tricky. That's so tricky. I just want to say I'm so sorry that people feel like they're not being listened to. That's absolutely unacceptable. Be the squeaky wheel. Get the help you need. Just be the squeaky wheel. Whether it's symptoms you're concerned about that have not resolved with moderate or initial measures, or whether there's a family history. It depends on, of course, insurance, as Heather was mentioning. Sometimes insurance factors can be a barrier, but be the squeaky wheel. Unfortunately, I've seen too many young people get turned away over and over again, just like Heather said, from primary care, from urgent cares. It's not to say that they're not doing their job properly. It's just they are not thinking worst case scenario, but demand the rectal exam if that's what's going on. Demand, see your GYN. Whoever will actually do the physical exam and do your labs. You really got to be the squeaky wheel.
That's absolutely true. And just to the listener who posted that question, you being on here, you're obviously, an advocate for your patients. So we thank you. And continue, like Rachel said, continue advocating. If you're having trouble within your own practice of getting those patients' needs met, there's always somebody out there, somebody in leadership. People want to listen. They do want to help. Speak up. Continue to advocate. We would say to our patients, continue to get involved like Heather is, either at a cancer support community or Colorectal Cancer Alliance. Be on the Hill, continuing to advocate for more laws and for more screenings and for more testing and for more research out there. Just be a voice.
And I want to add one more thing, a comment I received earlier in the chat before we close out, Rachel, is there's thanking Heather for your feedback and sharing your experience. She says it's so incredibly valuable. Wow. Thank her so much for sharing all of this, especially because some of these topics are, vulnerable situations, and they think your input has been fantastic. So I just wanted to share that
Thank you
comment.
so much. That's very kind.
Thank you, both Heather and Rachel, for an amazing discussion. It was really personal and intimate. We touched on a lot of different subjects, and we can't thank you enough for being advocates and a healthcare professional and a real patient advocate and voice out there for our community members, both of you. So thank you a million, and we look forward to hopefully going on another webinar with you sometime in the near future. So for everybody out there, we want to thank you for joining our webinar this evening. Thank you to our sponsor, Merck, and our partner, Colorectal Cancer Alliance, for their generous support of this evening's event. This event has been recorded and will be made available at www.cancersupportcommunity.org/colorectal/cancer. We hope to see you again soon. Stay healthy and have a good holiday season.